Hello, good afternoon. It is a lovely Saturday afternoon, and I am excited to be here with you today talking about the OMT Dream Team. When we're talking about myofunctional therapy, oral myofunctional therapy, oral facial myology, or whatever you want to call it today, we always have to think of it as a team event or a team modality. It is not something that solves any problems just 100% on its own. And so we're going to dive deep into some of the specialties that it helps. While I would love to sit here with you for like 3 hours going over all the various specialties and everything that it really does help with, I really just picked out some of the most common ones and we'll touch on everything else towards the end. So let's start with just a very warm welcome. Always love to make sure that you can see me, that you can hear me. So just give me a hi, hello in the chat. Just throw something in there. That way I know you can see, you can hear, and that we are going on and going forward without any sort of technical delays, because that's what always happens. There's always something technical that goes on. That's just the day and age that we live in. We anticipate it and, just have grace. Also want to remind you to just let's keep this going. I'm your Myo best friend, Carice Laguerre, and I am here every single week. I wasn't here for the past couple of weeks, and so this week you got a bonus of 2 live lectures, but I'm here all the time giving away free lectures, free content. Next week we're going into treatment planning, and so I'm a little nervous because I'll be sharing all of my trade stuff and everything that kind of goes into how I develop a custom treatment plan. But there's just so many people who need that, who've spent so much money investing in the wrong places where they have no idea how to custom treatment plan. And I keep getting the same questions over and over and over. And without having people invest in an entirely different introductory course just to learn how to treatment plan, I feel it's very important for us to get to talk about that so that you don't miss that lecture, because it has not been planned yet. I can't give you a date and a time. Make sure you're subscribed. If you're watching this on LinkedIn, send me a connection request. Let's connect. Let's get together, and we can learn and grow and really build up myofunctional therapy to meet the standards upon which it should, which in my opinion is excellence. We need to all elevate to excellence, and that is the bare minimum that we should be on as a community and as a field. Turn on your notifications if you're subscribed onto YouTube. That way you don't miss any of my live lectures from here on out. There are over 50 of these. If you want to go back through the library, they're all there for you. Comment, like, and share. The more you share, the better it is, because it really does push it out to a wider audience. It tells YouTube, it tells LinkedIn that it really needs to push this out to more people. And in the dental industry, we are struggling with myofunctional therapy. And it's time that we stop that, because we are primed, skilled, and exceptional to the point where myofunctional therapy originated in this field, and it can excel to excellence in this field if we are all on the same page. Okay, I'm tired of mediocrity. That is literally the word that irks my nerves, and there's so much mediocrity right now in myofunctional therapy. So we're changing up the standards and the norms. Okay, you guys ready for some real, thought leadership here? Let's dive deep. All right. So there's a dream team, and the dream team is typically going to consist of a bunch of different providers. Now, as much as I would like to say that this is a comprehensive list of every provider that you could possibly want to work with, it's not. It's a pretty full list, and I'll tell you that I have, a lot of resources for each of these. There are some things that aren't there. Hypnotists, some other energy workers, a breath worker. If you don't personally do breath work, it's always helpful to have someone who does. But typically everything is going to kind of divide up into these 4 categories of dental, medical, motor skills, feeding skills, or manual therapy. And there's some overlap in all of these. Like oral maxillofacial surgeon could go in medical, or you could have your medical esthetician kind of working in a little bit of a different vein under manual therapy sometimes. Some of the tools and things that they use could be used in other realms. Physical therapists could also go into motor skills. Like a lot of these kind of cross each other in some different ways. But you want to have a team that is as full as possible and really comprises of as many of these individuals as you can. So we're going to go through most of these individually and talk about how myofunctional therapy really does complement all of these specialties. It's not just that our clients, patients, the people who we're working with who are doing the myofunctional therapy, they'll benefit. The providers on the other end that we're working with and collaborating with, they will benefit. They'll get improved and enhanced outcomes. They'll be able to get through their work faster and vice versa. It's bi-directional. We'll be able to get through what we can get through faster if we collaborate with others and we're able to really check off goals together. So let's dive in, starting with the dental world. And I wanted to start with what seems like it might be the most obvious. I have a whole lecture on how myo works well with ortho and when it definitely doesn't, and why most orthodontists are very reluctant to work with a myofunctional therapist, and why many of them may be right. Okay, so that is a very controversial topic. You can go back to that lecture. I believe it was 45 minutes or an hour long, and it's on YouTube and or in the LinkedIn library. If you need the direct link, let me know. You can always reach out to me at any point in time. But this orthodontist does not have to be airway focused. A lot of people think the only people I can work with are orthodontists that are airway focused. No, that's not true. It's a complete farce. There's so many people you can work with. They don't have to be airway focused, but they do have to have the mentality where they are forward thinking enough that not every case needs to be retractive. Now, what you want to avoid are the people who are going to be pulling things backwards, right? So you see a recessed mandible, they see an advanced maxilla, and they're trying to bring everything back. You want people who are going to advance the mandible, who are going to advance the maxilla where they can too, who are going to avoid any sort of extraction, retraction devices. They might be very forward for a reverse pull face mask. They might be looking to do treatments that you wouldn't anticipate in traditional orthodontics. So OMT is going to complement orthodontics in very obvious ways because many OMDs are going to impact craniofacial development. And one of the key signs that I've always been told, and I'm sure everybody else has been told, when you take a myofunctional therapy course, one of the key signs that somebody needs myofunctional therapy is malocclusion. And every orthodontic patient has malocclusion. And malocclusion is actually the source of myofunctional therapy, right? So it starts with Edward Engel, who created that whole system, the whole classification system for malocclusion, and his forward thinking, and then the people who were directly under him who wanted to know why this is happening. And it comes down to the soft tissues and how the soft tissues are going to impact the hard structures and the craniofacial bone development, the dentition, where that all sits. That's very much impacted by the soft tissue pressures, those light constant soft tissue pressures that are happening intraorally and extraorally. So with that said, we should be collaborating with every orthodontist on every case, but that's not reality. Okay, one, not everybody is going to be committed to myofunctional therapy because we know myofunctional therapy is commitment based. It's very compliance based in how it is originated. We need people to actually work the program in order to get the results. And that's not going to be everybody. There are people who fail and don't do everything they're supposed to do with their orthodontic treatment. And so you're not going to get everybody. You probably won't even get 80. I'll even be generous. You probably won't even get 60% of the orthodontic patients. So don't expect everybody to be flooding your schedule. But there will be people who do understand the connection, who will be willing to commit. There are orthodontists who will refuse to do a second or third round of orthodontics until there has been intervention by the myofunctional therapist. And 100%, we are a big part of eliminating all of those noxious oral habits that contribute to or perpetuate the malocclusion in and of its origin and how it is actually exacerbating the problem. Now, our our elimination of oral habits. It does also help in trying to avoid doing more passive, punishing appliances. I don't know how else to say that nicely, but more punishing appliances like a tongue rake or a tongue crib that are just going to prohibit the tongue from doing what it's supposed to do, but it doesn't teach the tongue to do what it is supposed to do. It's not working on the intraoral soft tissue pressures against the palate or anything else. It's just really preventing them from doing a thing, but not teaching them how to really remediate. And so once that appliance is typically removed, you still don't know what it is you're supposed to do. Like if you wrap my arm up in a sling and I keep it in a sling for several months, I would assume that after I come out of that sling, I'm going to need some rehabilitation and figuring out what it is that I'm supposed to do with my hand. There's going to be some atrophy. There's going to be some stuff that's going on wrong. And we think about that in a more global sense because nobody would ever think about going into a situation where there is some surgery or where there is some alteration of your physical form, like you being in a sling or being in a cast or being in something, and then there is no physical therapy afterwards. We should think about that too with orthodontics, that there is going to need to be functional remediation to help us push forward. If you are interested in learning more about like appliances and what appliances can work with Myo, or how to sequence and stage, or how you would understand or know what type of orthodontics there are available, because there's so many different types. Brackets and arch wires are not all the same. What types of orthodontics are more forward dontics in what we might call it, or what would really work great in orthotropics, and some sleep medicine oral appliances as well. The Device is Right course is in the Myo Launch Library, and that is a fantastic place for you to learn more. But the orthodontist can really be almost anywhere in your treatment plan. So when you're collaborating with them as a myofunctional therapist, it could be prior to starting Myo. You want to know what's going on. Is this a case where they will like to expand and get into anything that's going to open and bring forward our maxilla, or you want to be in there immediately after the expander is done. Some people work during the expander. I don't like to fatigue people. If you're going to be in expansion for 6 to 9 months, why are we working together when I can't get through all of my goals in that time? And then we're going to have to still work together for an additional 6 to 9 months after that. It seems like a greater waste of time for all parties involved. But there are a lot of appliances that you can work with and work through, and so your orthodontic collaboration can really fall in a number of places and spaces. Okay. Sleep dentists. Dental sleep medicine is not talked about nearly enough in myofunctional therapy. It is incredibly disturbing because we talk about sleep all the time in myofunctional therapy, and then sleep dentists tend to ignore myofunctional therapists, and myofunctional therapists tend to ignore sleep dentists. Neither one should be working in a silo. Neither one. A sleep dentist might be the first one in dental sleep medicine in all the world that I've been listening to, and I've been diving a lot deeper into that world, and I love collaborating and working with dental sleep medicine specialists, the diplomats, and the people who are like very advanced in the field. I love working with them because when you really understand what the appliance is doing, yes, it's working on advancing the mandible, yes, and that does advance the tongue in the space, yes. And in certain instances and certain appliances, it's going to have a wonderful positive effect on really bringing up and engaging that genioglossus, and so you'll get the tongue out of the way. But what happens to the velopharyngeal space? I'll wait, because nobody seems to be able to answer that question within dental sleep medicine and in myofunctional therapy. So many people are just like, I don't know. I don't know what happens to that. Well, some appliances, there has been research to show that some appliances do actually positively impact the velopharyngeal corticomotor strength and space. And so you are having a positive impact, but it also doesn't help. It doesn't make it long lasting. It doesn't keep it managed and navigated throughout the day. It is something where you do still want to collaborate because they need that awareness. So bringing it to the forefront and having the awareness. If you're using a night lace, if you're using Sonoma Sleep, if you're doing any of the laser treatments targeted towards the soft palate and the velopharyngeal space, you're doing that for a reason. You're trying to engage the collagen, engage that musculature, and tighten it up. That way, it is opening up the space more. Guess what myofunctional therapy does? And on a more permanent basis. And so you are looking down different avenues to really avoid collaboration when collaboration is actually the best thing you could possibly do. And a myofunctional therapist is really a big advocate for a lot of the specialties upon which we collaborate with. Nobody's going to tell you more that, like, okay, your insurance doesn't cover ortho, but here's why you need it. Like, nobody's going to advocate more that it's not just a cosmetic thing. This is a health and a lifestyle thing that we have to do. Nobody's going to advocate more for that oral appliance, whether or not your company is able to get medical billing to reimburse. Like, we're going to advocate for the sleep dentist. That's a wonderful way that we complement, because not everybody's getting all the case acceptance. There's a lot of underground stuff that nobody's talking about there in myo and in sleep dentistry, but like sometimes y'all aren't getting the case acceptance that you want to talk about. Like, it's like, oh, we're presenting it, but like people aren't picking it up, or people just don't seem to care. Nobody's going to be your biggest advocate for each other than you. It's a wonderful mutual referral relationship that really does benefit at most the patient, because they are going to be achieving more of the soft tissue health and strength that they need to facilitate more patent airways, more open airways, and more compliance with wearing this oral appliance that they are essentially prescribed for the rest of their life. Yes, you're changing over your oral appliance every 3 to 5 years, but I mean, it's for the rest of your life. Okay. So your collaboration is always during myofunctional therapy, throughout your myofunctional therapy program. Very rarely am I mean, sometimes I might get people who are like, I don't know what to do about my sleep. I hate my CPAP. I want to do the myofunctional therapy, but I don't know that I want to do my CPAP. And I'll be like, okay, well, you probably need to see a dental sleep medicine specialist, because that's going to be the person who's going to get you the appliance that is going to really take things to the next level. Okay. Oral maxillofacial surgeon. Our oral surgeons are dual MDs and DDS or DMDs, so they're dentists and physicians, and they surgically manage any physiological barriers to craniofacial space and development. They do a lot more than that. They do a whole lot more than that. But for the purposes of this lecture, for myofunctional therapy, that's what their role is. So when you have somebody who needs a UPPP, I'm not even going to try to pronounce that, but you know what it is if you're in the field, or a maxillomandibular advancement surgery, or any other types of surgery. It's really, really important to collaborate, because oral myofunctional therapy is really going to help them prepare adequately for the procedure. Those soft tissues and functional strength, we're going to get them to a point where they'll be okay during some of the healing period where we can't work together, where they won't be able to open their jaw for some times, where they're only having soft food and they need to be able to swallow that food appropriately and not have a whole lot of gas and not exacerbate typical digestive issues that they already have already. And we're going to help to manage the recovery collaboratively. That way they can functionally rehabilitate. That way they're able to actively engage in all the functional movements that they need to in order to recover from whatever the procedure is. Our collaboration with oral maxillofacial surgeons is always prior to a surgery, if we can, if they come to you. Sometimes they don't come to you till after. Sometimes the oral surgeon already has them scheduled, and then their office calls back and reminds the patient, okay, your surgery is coming up in 10 days, we're confirming. Your surgery is coming up in 7 days, we're confirming. Did you reach out to your myofunctional therapist? Have you been working with your myofunctional therapist? And they might be like, no, let me call them now. And then you get that phone call and it's like, look, your surgery's in a week. There's not much I can do to prep you in a week. but we'll work together post-surgically, and we'll make sure that we get you the best healing outcomes collaboratively. It's incredibly important that you are communicative. I hear from a lot of doctors, sleep physicians, orthodontists, general dentists, airway focused dentists. I hear from a lot of them when I'm talking with them, when I'm doing any sort of consulting, when I am just at a conference. I hear a lot from them that myofunctional therapists are not communicative, that we do not write adequate reports, that we are not keeping updates, that we are not taking that referral and managing it in a way that they feel is just. If we are getting a referral, that is a sign of trust from a provider. If I'm sending anybody that I'm working with and putting my name, my reputation on the line to send them to you, I need to know that I trust that you're going to give them the utmost care, that I trust that we're going to be able to achieve the most successful outcomes in this collaborative relationship. And just having them refer to you but you never send any information back is not the way to go. You have to send back the information, the updates, and let them know what's going on. So it's very important that you're super collaborative and communicative, I should say, communicative in your reports, in your updates, in your progress reports, and that you're letting them know where you're at. Even if some of that communication is through the client or the patient. If it's through the patient, like you're giving the patient a form, I do that a lot too, because sometimes I don't have the direct permissions. So I will, in my HIPAA notices on registration, ask who I can share information with. If you're not giving me permission to share it with your surgeon, with your dentist, with your whoever, you want to have that information and selectively share what you want to share, that's fine. I need permission before I can just send out your reports, before I can send out whatever documentation I might have about you. I need your permission. And so if they are the conduits of that information, make that known. Just say that, as I have been working with Jane Doe. Jane Doe has said that they want to be the person to hand off the reports. So Jane Doe was issued a report on such and such date, such and such date, such and such date. If you haven't seen it, please ask Jane Doe to share and or to allow me permission to directly send you the documentation. But it's important that you communicate. I just hear this a lot from the surgeons. They're like, we don't hear from anybody. We don't hear from anybody. We send them out and we have no idea what happens after that. And it's really important because surgery is a high responsibility, and the recovery is incredibly important for the outcomes of the surgery. And so working together is the only way to make that happen in a way that's going to be positive for all parties involved. Okay. Sleep dentist, we already did this, right? I'm surprised I had that in that twice. Okay, physician. Physician. Our physicians can be a MD, a medical doctor, or a doctor of osteopathy, or sometimes you could sub out in Florida, where I am currently. There are a lot of PAs and nurse practitioners, so physician assistants and nurse practitioners, and they are like the primary care people. And so you'll go there and you won't see an MD or a DO. You'll go to your doctor and your doctor's office, if it's like a big practice or it's like a big whatever, it's like a, let's say Capital Health, which is not down here, but let's say it's Capital Health and it's a big conglomerate of health and wellness. And you'll go and you'll never see a DO or an MD. You will only see a PA or an NP. And it's very interesting because I don't know exactly how that works. And maybe in different states, like the practice acts are different, and so there's different responsibilities. But essentially you want somebody who's the primary care physician to be on your team and or to just be aware of you, that you exist, that this is your role that you're playing in their patient's health and wellness. So as a myofunctional therapist, you are going to help establish proper oral rest posture, which creates many happy accidents in systemic wellness. And that is something that you can co-manage. So your physician is going to be able to prescribe the labs and, give you all whatever data, or give the patient directly the data. And with that data, you can make your recommendations. You can also, kind of cater your program to that. In the Myo Launch Library, the Myo Gut program, I talk a lot about what there is that you can do as an individual to get your patients labs. So you can ask for certain labs, and it's a very interesting concept, but that can help to inform how you manage gut health, how you manage their digestive care, but you're not necessarily managing it, but you are just making sure that you are taking all the precautions to ensure that everything you're doing in your area of wellness, where digestion starts, is being optimized by the time it hits their gastrointestinal tract. Okay. They're also able to write prescriptions. So there's a lot, or referrals, real referrals. Had a conversation with somebody yesterday who was asking about that specifically. Like, as a myofunctional therapist, can I do referrals? Technically, no. Like, you are not a actual provider. You can't write a real referral, but you can make recommendations. And so in the insurance sequence, for a lot of people with certain plans, you have to have your primary care physician send you to a specialist. You can't just make an appointment with a specialist. And so that's okay. What you're going to do is you're going to make sure that you are actually working with them to ensure that whatever recommendations you're making, they kind of are on board, or for whatever reason aware. That way they can help to facilitate that. If you've never collaborated with a physician, I'll tell you that it takes a lot of communication. So if I was light about the amount of communication you would need with an oral maxillofacial surgeon or anybody that you work with, I'm going to be heavy on how you need it with a physician. So physicians are always more skeptical, especially for anything more like holistic, or like, what are you doing? You're doing myofunctional what? That's nonsense. That's a pseudoscience. Like, okay, what are you going to do next? You're going to have a sound bath? Yeah, probably. I think a sound bath sounds really good. But what you want to make sure that you're conveying is that, hi, I am Carice Laguerre. I'm a myofunctional therapist local to the area. I've been working with such and such. And in our treatment plan, we are working to resolve improper oral rest posture, which has contributed negatively to overall sleep, mental clarity, daytime fatigue, da 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 da. It has contributed to whatever. Please reach out with any questions. I've recommended that they see an ENT just to understand if there are any physiological barriers to nasal breathing, which would prevent us from achieving our goal of establishing proper oral resting posture. If you have any questions, happy to chat anytime, and yada yada yada. Reach out again. Stay on top of it. Like, you have to keep going. It's really important. You can't just let it slide that whatever communication you sent out didn't get answered right away. Keep pushing those doors. How you follow up really, really matters. Okay. And you collaborate with the physician throughout the entire time you're working with your client. Like, if you're working with them for a year, that whole year, you should be in contact in some way, shape, or form with that physician, with updates and follow-ups and so forth. A naturopath. Ideally, we want our naturopath to be a ND. That means they actually went to medical school for naturopathy. I think I said that correct. For naturopathy. You want to be mindful that there are some coaches, like health coaches, that call themselves naturopaths, and there are some like schools, just like how there are myo schools, there are schools for naturopathy, and those schools are kind of teaching health coaches how to do similar work. They're not naturopaths. They're in absolutely no way, shape, or form naturopathic physicians, but they consider themselves kind of like that. And so just be mindful. If there's no ND following their name as a credential. They did not go through medical school, and they're probably not as helpful as you would like them to be, because your naturopath is really like your physician, but more function focused, like your functional medicine doctor, your holistic doctor that's going to be more on board. Like, I love a good naturopath. The naturopaths are very, very invested in what we do as myofunctional therapists. They understand the connection. They are the greatest referral source, because they're going to send people your way, and likewise you're going to send people back to them. You're going to be like, look, I love your physician that you're working with now. They've helped you get to this point. I want you to see this naturopath. This physician is actually really function and health focused, and will provide you with some natural alternatives that we may not have considered before. And so I think they're a wonderful person to work with, and that's why it complements each other really well, because they understand the importance of function and overall systemic health and wellness. And so you're able to co-manage wellness really, really well. You'll work with them same as a physician throughout the entirety of the time that you're working with your myofunctional therapy program. You don't have to be as communicative as you would be with a physician, but you should be equally communicative as you would be with a dentist, with anybody that you're regularly updating with patient progress when you hit certain milestones of your program. Sleep physician. A sleep physician is sometimes just a sleep physician, like a doctor who specializes in sleep. So an MD or a DO that specializes in sleep. Or there might be a pulmonologist. So they're specialists of the lungs and breathing and respiratory care. And so that's what they are. That's what they do. They're going to help to diagnose and medically manage sleep disorders. There's a lot of ways that you can do this, and you can kind of get through this. You can also have some respiratory therapists are doing this as well, are helping to navigate diagnosis for sleep disorders and so forth, remotely with home sleep studies and so forth. Your sleep physician is going to love you if they are very forward thinking and if they're looking for alternatives. So the ones who are already working with dental sleep medicine specialists, who are working with sleep dentists, they're going to understand your role, and they'll really understand it really well. They'll be able to highlight and speak to that exceptionally well. The way myo complements proper oral resting posture. We want the tongue up and out of the airway. We want to establish patent nostrils. We want to establish oral pharyngeal space. And so the velopharyngeal space, we're working and we're targeting and we're opening up the airway more naturally. I always do this analogy where I say it's kind of like you take a person, right, who has six-pack abs, and just imagine, I don't care if it's a woman or a man, you take a person who has six-pack abs, you imagine them on the beach. They're going to lie down because they're tired of, traipsing through the sand carrying their beautiful body. So they are lying down. Those six-pack abs go nowhere. They lie down, and those abs are wonderful, despite the fact that gravity imparts a pressure on us when we are horizontal that it doesn't impart in the same way as when we are vertical. So now let's take in comparatively a person who has more of a beer belly, or just is not abdominally blessed, okay? They have more of a round shape in that belly area, that midsection. Now, we're going to lie them down. Does everything sit up the same? Does that beer belly sit up the same? No. No, in no way, shape, or form does that beer belly sit up the same. It's very altered. And it's the pressure of the gravity, right? So we have gravity imparting a pressure that is going to change things. Now, when we think about that, I want you to think about us with sleep. If you have an airway and you have not worked on the muscles, you have not worked on that musculature, those soft tissues are very beer belly like. We're not working on that area, very obviously, if it looks like a beer belly, right? And you do all the work of a myofunctional therapy program, that corticomotor strength in the pharyngeal area, in that oral pharyngeal space, the velopharyngeal space, in the you're working on nasal hygiene and nasal breathing, and you're establishing patency, strength, awareness of that space, now you've got a six pack airway. And that's more patent because when you think about a CPAP, it's a continuous positive airway pressure. So it's forced air that is opening by force your airway. So it's just pushing the air and keeping everything open. But if the first stage of sleep is muscle relaxation, that just gets progressively more. And then the second impact you have is gravity because you're lying down, you're already horizontal. That's going to make you more prone, if you're beer belly like, to airway collapse. Whereas if you've got your six pack airway, you're able to sustain more patency on your own. You're able to sustain more of that patency on your own in conjunction with a CPAP. And that's how it helps to enhance CPAP compliance, because now your CPAP doesn't feel as invasive. It's not pushing against your airway as much. Your airway is able to sustain itself a bit more, and your CPAP is able to facilitate less pressure, opening up the space. And so it's not as invasive. And so, in a way, your sleep physician is going to be your greatest advocate because they understand these concepts. They understand what's going on with the airway and with collapse, and that it makes sense that that soft tissue should be worked on and that whatever. And so, incredibly important to collaborate with a sleep physician. Also, for understanding where you are. Are you actually helping? Are you not? There's so much more data. There's a reason why a polysomnograph is the gold standard. You want all of the high quality data that you would get from an in-lab sleep study. If you can't get that, then fine, a home sleep study is fine, and you can just work off the data that you're getting from that. But working with a sleep physician, you're more likely to be able to have repeat studies and be able to see the progress that you're making. So you want to work with them before starting a myofunctional therapy program. Oftentimes I send them to a sleep physician before I send them to an ENT. That way the ENT is more likely to take us seriously, like, oh, there's a problem. Okay, let's scope now. But the sleep physician should definitely be like one of your first steps, one of your first thoughts for anybody who is experiencing issues with their sleep or complaining about sleep, or if you do any of the sleep screeners, you want to know where they are there during the myofunctional therapy program, and definitely after. That way you know where your results lie. And ENT, so ENT specifically, the slide followed the sleep physician because that's technically the order that I always do. But an otolaryngologist, or an ENT, which everybody prefers to say over an otolaryngologist, is going to diagnose and treat upper respiratory blockages, disorders, and physiological anomalies in the ear, nose, throat space. They complement, or OMT complements ENT very well, because we're dealing with the soft tissue dysfunction in the same way that I explained with the sleep physician. So I want you to understand that ENT is not like a one-stop shop. It's not, they have subspecialties. Not all ENTs care about pharyngeal space, sleep apnea, and so forth. Some are really just specialists for other areas. There are some ENTs that are specialized only in, cancers, so oncology of the ear, nose, throat, upper airway system. There are specialists that will focus in on just sleep. There are specialists who focus in on just pediatrics, specialists who focus in on tonsils and adenoids, or just the nasal pharyngeal space. And there are some who focus on just the oral pharyngeal and the regular pharyngeal space. There's not a global, like, ENT just means they do everything. That's not how it works. It's just like how some dentists are not all general dentists do all things. There are some general dentists who will place an implant. There are some general dentists who are not opposed to doing root canals. And then there are some who always will refer out because that is not their lane. They don't want to do a root canal if they know that they can't do it exceptionally well with the same kind of treatment or caliber of treatment that an endodontist can. So just don't think of ENTs. They're hard to get. They're very, very hard to get, but mostly because you're not focused on a subspecialty. In Myopathway, I have a whole lecture where we focus in on the subspecialties, all the different surgeries and things that they do, and how you can collaborate with them, and how best to approach that situation in order to enhance your ability to get an ENT on your team. And so I won't dive into all of that today, but you need an ENT. And there's a way to go about it that is more logical than just approaching every ENT you meet. Okay. You want to help them with establishing proper oral resting posture and optimal nasal breathing, because just removing tissue does not, in and of itself, help. So we've seen it time and time again as myofunctional therapists. When you have tonsils, adenoids that are removed, it doesn't change in any way, shape, or form anything. That is going to be like one of the biggest issues that you might come across with some of your ENTs and in conversations that you'll have with them. So prior to myofunctional therapy, throughout the myofunctional therapy program, it's incredibly important. Okay. Mental health specialist, and I feel like I have to rush through some of these now, but a mental health specialist, because now we're getting deeper. Now, mental health specialist, I did a lecture on trauma not too long ago. A mental health specialist is going to be incredibly important for managing and navigating any of the mental health issues or trauma that might be associated. You have no idea the depths of which, as a dental I can't call myself a dental practitioner. I don't practice clinically anymore. But as a dental professional, like somebody who understands and is licensed in a dental practitioner role, I am sad to see all the cases of abuse, of traumas, assaults that happen in the head and neck region. And we can't ignore that in myofunctional therapy. It's really unethical. It's immoral to ignore that. It's important to know all the signs and what to look for, and how you may unintentionally bring forth, bring more forward, because the trauma might be stored or repressed. You might bring it forward and bring it out of a patient unintentionally. And you can't navigate that alone. You're not a therapist of that type. You're a myofunctional therapist. You have nothing to do with their mental health. And so it's important to have somebody to direct them to. So whether that's a licensed clinical social worker, a psychiatrist, a psychologist, if you don't know the difference between those, please Google it. But there's very distinct differences between all of those. And it's important that you're really working with someone who can manage the trauma, because when you leave it unmanaged, we're going to have more and more and more issues that come about that are really going to lead them away from myofunctional therapy, lead them away from all the results and the outcomes that you're trying to get. You want to work with them throughout the entirety of the myofunctional therapy program, and anybody who expresses that there's trauma or that you may have seen trauma in. Medical esthetician. So, estheticians can be just somebody who goes to esthetician school. Like you can go to a cosmetology school, specialized in aesthetics, specialize in aesthetics. You could do like facials and certain treatments and work certain machines and do certain things, right? But a medical esthetician might be the one that you want more so. Sorry. I have this cough that just won't go away. I don't know if everybody knows, but I have 4 kids and 2 of them have coughs, and now I have the cough, and so it's been bad. Okay, so medical esthetician is going to specialize, be a medical doctor. So a doctor that specializes in cosmetic medicine. There might be an MD or a DO. And they may or may not surgically manage it. So it could be a plastic or cosmetic surgeon. I'm trying not to die on this live stream. That would be sad. Okay. They're going to help to diagnose and manage various skin or muscular concerns in oral facial regions. Sometimes they're doing Botox, fillers, implants, things that are going to impact their ability, your patient's ability to manage muscularly, your myofunctional therapy program recommendations, and so forth. So it's important to be able to collaborate. Myoaesthetics is a whole course in the Myo Launch Library that goes over a lot of this, but it deep dives into it, I should say. But your myofunctional therapy is very important in being able to establish muscular strength and function that's going to aid in the cosmetic outcomes that the patient's seeking and optimize what may be there or may have failed in their pursuits with Botox or fillers or whatever. Okay. Your collaboration is throughout the entirety of your myofunctional therapy program because likely they're invested in multiple different options. So if they're getting facials, they're getting, you know, specific facials once every 2 weeks or once a week or whatever. They're not going to stop that. So you just want to make sure that you're co-managing how everything is going so you can get the outcomes that they're looking for, they can get the outcomes that they're looking for, and everybody's happy in this wonderful collaborative team. Occupational therapy. So your occupational therapist might also be a myofunctional therapist. A lot of OTs, I would say a lot, but it's not a lot. But there are many OTs who do practice myofunctional therapy, and not all are seeking to do so to a full program capacity. Some are using it to just help them with some of their occupational goals that they're trying to reach with their clients. So what you're going to be doing is helping to resolve they're resolving sensory motor or feeding issues, and you are helping because you're dealing with fine motor skills, but the occupational therapist is dealing with their gross motor skills or sometimes other fine motor skills, and they will refine down from those gross motor skills towards the fine motor skills because it's really difficult for us to be able to do the fine motor work when there are gross motor issues that are involved. Think of primitive reflexes and so forth. Like there's global issues that are going to cause issues that you're trying to get really niche in the body. And that's throughout the entirety of the myofunctional therapy program that you want to work with your occupational therapist if they're already working with someone. If they're not, you might be referring them out and sending them to work with someone. Lactation consultant, we need to talk about more often. I think people dismiss it because they're like, Myo's not for babies. You're right. Myo's not for babies. We shouldn't really be doing very much of anything in this like 0 to 3 age. Fine. Totally agree. Okay. However, with lactation, I think it's incredibly important, and what we downplay the most is anticipatory guidance. There are a lot of people that go straight to a release provider. We'll go straight to an ENT. We'll go straight to a dentist. They're like, hey, my baby has a tongue tie. Like, can you release this? They release this. And then there is no sort of preparation mentally, physically, for the work that's involved in healing with active wound management protocols that we have in our traditional stretches and guidance and so forth. And so you can imagine, who knows the trauma that it took to get to this point? Who knows if this was a baby that was a struggle to conceive, if there was a lot of IVF, if there were fails before this, if this is like the rainbow baby, and then everything doesn't go to plan with the labor. And you have this vision in your head sometimes as a mother, and like, this is how it's going to go. I'm going to have a natural labor. It's going to be great. You might wind up with a C-section or a vacuum or drugs that you didn't think that you were going to take. And everything's been going wrong. So now everything's been going wrong. Up now, baby has a tongue tie. Okay, baby has a tongue tie. Let's go get that resolved. We're working on the feeding. The baby has this tie. Maybe I'm not seeing any outcomes. And the doctor says I'm not stretching appropriately. Like, I don't know what I'm doing. It's overwhelming. We don't even know if they have the support from their family and friends for doing this release. There's a lot of people who are doing that as like a silo where their partners may not be receptive for them doing the release on the baby and might want nothing to do with it. I'm not going to help you with those stretches. I didn't tell you to do this release. It becomes overwhelming. I think it's really important to have a myofunctional therapist who is, I'm going to say trained. I'm going to say trained to work with tethered oral tissues in a way that they can help to educate the parent why this is important. Get under the tongue prior to release. Let them get at least a week of practice getting under the tongue, lifting the tongue up. You're to hear that baby scream. If I put my fingers under your mouth right now and start lifting up your tongue without your permission, you're going to be like, well, what are you doing? Like, you're going to resist. You're going to scream. You're not going to like it. The baby's going to scream. The baby's going to writhe. The baby's not going to like it. But you understand cognitively that, look, the baby doesn't like this because I just got my fingers in their mouth. Like, they really just don't like that. And it makes it less traumatic if the first time you, as an unlicensed provider, like you haven't worked in anybody's mouth ever, have to now go into your child's mouth, your newborn's mouth, your baby infant's mouth when there's a wound in there, and you feel guilty as all get out, guilty as all get out, that you were responsible for this. And so now you've got to go in there and you feel like you're hurting the baby and the baby's screaming. We understand if we start getting the practice in beforehand, baby starts thinking that, hey, this is some weird thing that mom and dad does. And so they just get in my mouth. And the more you're doing that leading into a procedure, the less unusual it is when you're doing it after the procedure. Okay. So you're getting in there and you can manage it homeopathically. You can manage it with a little bit of like baby Tylenol or whatever it is that you're using to manage whatever your doctor's prescribing for you to help manage the pain. But you're getting into a sequence and you're understanding what you're doing. You're feeling confident about your holds and your stretches, and you're more prepared. And so the more lactation consultants that are working with myofunctional therapists, and if the myofunctional therapist is able to help the lactation consultant, or if the release provider is able to help the lactation consultant be a conduit for getting these families prepared pre-release and not just saying, oh, go do it and do whatever stretches they tell you to do, it's not helpful in that way. Okay. So the more we can work together, the better off everybody is, and we can manage that anticipatory guidance and help with the mental health of a lot of these moms. You're not just working on the baby. It's not just a release on the baby. It is a mental management that you have to deal with too for the parent. Okay, for the whole community that's dealing with this baby, you have everybody, and you need to make sure everybody's on board. And if they're not on board, that you understand and that you feel confident to still continue on, and you understand the depths of which this is going to be. Because there's a lot of people out there with regrets who wish that they did not do what they just jumped right into. They wish they knew more. They wish they practiced more, and we can do better. This is what I'm talking about when I say we need to rise to the level of excellence as a field. We shouldn't be discounting the magnitude of which we impact people's lives. Okay. Physical therapist. Physical therapist could also be a myofunctional therapist. They're going to help to resolve motor or muscular issues, and that can include manual therapy. They get in there and they really like help to stretch you out and eliminate strains. But sometimes those strains don't stick. Like eliminating the strains, I should say, like releases don't stick. Now, why don't they stick? Like, why is it that you might find yourself going and doing massage therapy every week or every 2 weeks, or you're doing craniosacral therapy and you're just doing, and then you get tight again, and you're tight again, and you tight and again, and it never sticks? Well, because maybe there's a functional component that hasn't been addressed. Like if you've got terrible posture and you're working in dentistry and you're in the op and you're doing that all the time, and your ergonomics are atrocious, maybe if we fix that and we deal with the functional component that is exacerbating the issue, maybe some of your sessions with your massage therapist, your chiropractor, whatever, would last a little bit longer in between. And so We're really helpful at dealing with the functional remediation of the orofacial muscles, like the issues that arise in the head and neck area. If we're dealing with some of those functionally, it's able to maintain a little bit more of that fascial strain that's been released from the physical therapy. And we're just really, really grateful to have specialists like physical therapists who deal with pelvic floor. There are some specialists within physical therapy who deal with pelvic floor or hip imbalances or posture. And that is going to complement what we're doing. Glossopostural syndrome, we're dealing with the diaphragm significantly in myofunctional therapy. That's the top of the pelvic floor. Like, we're complementing each other in a lot of ways because many of our goals are very similar. Collaboration is always prior to a myofunctional therapy program or throughout the entire myofunctional therapy program. An osteopath. Okay, so as we start winding down, because I'm really winding down with manual therapy, an osteopath, I think, is the gold standard of manual therapists or release providers. Why? They went to medical school. Okay, I love me a good osteopath. And I don't love that there's like this hierarchy where MDs feel they're more superior to DOs, or like it's easier to get into osteopathy school than it is to get into medical school. I don't care about any of that. I prefer always a DO. Now, I like a DO that they could do traditional medicine and, whatever, but I want a DO that's going to get their hands on people, that does the osteopathic manipulative medicine, that will deal with the strains by their hands. So in a similar way that I just discussed with physical therapy, for an osteopath, for a chiropractor, for a craniosacral therapist, for a massage therapist, it's really just generally going to be all the same, that we're really helping to maintain the stickiness of their releases and the work that they're doing. Why do I think that a osteopath is the gold standard? Because everything else is a sub, I don't know, like everything else kind of branches off of osteopathy. Osteopathy is the gold, and everything else is like it wants to be osteopathy, but it's just not. Okay. You're working with them prior to and throughout with TOTS, tethered oral tissue clients. So any sort of those cases, prior to and throughout working with appliance providers, and prior to and throughout working myofunctional therapy. Like, there's so many uses. I use a body worker for almost every single case. I'm always recommending that. Okay. So anytime there's any sort of tension, strain, oral facial pain, TMD, I need a manual therapist to do the work. An intraoral osteopathy is like fantastic too. So if they go in the mouth, oh, hallelujah. And many of them will tell you there's a lot of appliances that they don't like because it locks up the person. And so that really, like, they can't even do releases if they're wearing certain appliances or have certain things that are glued in the mouth. I don't know. But your osteopath is going to be like your gold standard. Okay. A craniosacral therapist. So John Upledger is an osteopath. And in 1970, he said, oh my God, osteopathy is phenomenal. Like, there needs to be so many more people doing this. I think I'll teach some people how to do this. And that's not the exact story, but that's pretty much the story, where it is something that they were trained to do osteopathy without all of the work that goes into actually going into school. And so they deal with, gentle manipulation of the synarthrodial joints of the cranium and cranium all the way through the sacrum. Okay. They're similar to an osteopath, kinda, but they lack medical school. They lack the ability to write prescriptions. They lack, a lot of things, any sort of regulations or accountability and so forth. But craniosacral therapists, there's lots of people who take craniosacral therapy. So a craniosacral therapist could be a massage therapist who's gotten additional training. It can be a physical therapist. I know several physical therapists who are trained in craniosacral therapy. It could be a number of people, but they're like a branch off of osteopathy, so they're not osteopaths. Okay. Chiropractic care really came from Dr. Daniel David Palmer. Dr. Daniel David Palmer in 1895 finished his first year of osteopathy school, and after finishing osteopathy school, he was like, "What? Like this is wonderful. Look at all this stuff we can do with the spine. I want to teach people this." And so forth came, and these are not like the entire stories, but it's a great summation of the story. This doctor of chiropractic medicine was born from that. So they're not trained through medical school. People call it a pseudoscience, even though it is um, an outpost from osteopathy, and osteopathy is very legitimate. Okay, so your chiropractor is like another sub tier down from your cranial sacral therapist. But I know a lot of phenomenal chiropractors who are very well trained and good at what they do. And so if it can't be an osteopath, I would probably recommend like a very highly educated and trained chiropractor or cranial sacral therapist. Okay. Now, to kind of wrap this up, because I know we're at time, can we work with everybody and can we do everything? Absolutely not. We can't. We can't. It's not possible. There's a lot of things we can't work with. There's trigeminal neuralgia, there's severed nerves, there's all sorts of things, idiopathic condylar resorption. There's a whole list of things I could actually put out that we can't work with and that we need to just send out and ship out to other providers because we're just not there. We can't do all that we would like to do. But I would like to say that I think we've covered a great bit of quality things here that I wouldn't trade all the value that OMT has for anything else. I am just going to put up this one little comment here before we go. On LinkedIn, Haven Medical, myofunctional therapy certainly impacts various fields, showing the importance of collaboration. Yes, there are exciting times again. And I think that's a wonderful way to kind of sum this whole thing up. There are exciting times ahead. If you are interested in doing, myofunctional therapy and really just trying to figure out how you can work with some of these cases, feel free to book a call with me. I'm happy to chat with anyone at any point in time about all things myofunctional therapy. But for now, I'm going to let you go. Enjoy the rest of your Saturday. Have a fabulous weekend, friends. Till next time.